All right, guys, so this is the second part of the lower limb anatomy lecture series. Remember, we have 3 parts total. I hope everybody enjoyed class on Wednesday as we covered the gluteal region and a little bit of the thigh region. Today we're going to be covering the thigh, the knee, and the leg. And I know that's kind of a lot to cover in one of these lectures, but we'll try our best to kind of take it little by little. And I think repetition is key when we talk about anatomy because it's a lot of memorization. So the more times you hear me say it, the more times you read it or watch a YouTube video about it, the easier it's going to be for you to remember it. Before we get into the thigh, I wanted to kind of show you what I was trying to show you on Wednesday about the Trendelenburg sign. So when we're talking about the abductors, the gluteus medius and minimus, they lie kind of here towards the posterior portion of the hip. What they do to the free limb is they abduct it, right? But when we're standing on one leg, these abductors actually keep the pelvis level. Okay, so as you can see in this one, it looks okay. When you get to this one, which is where the defect is, these abductors cannot lift the pelvis and rotate it this way. So he's using his entire body force to lift this part of the hip so that this leg doesn't hit the floor when he tries to walk. So this happens with the paralyzed abductor muscles. And I just wanted to show you a picture of it because it's one clinical correlation that you can see pretty clearly when you see a picture of somebody with that deformity. Another quick clinical correlation that I wanted to mention here is intramuscular injections. So, from time to time, it's necessary that we administer drugs intramuscularly. And that means that, we're going to take the needle, put it directly into the muscle. And we have to do this without injuring any of the neurovascular structures. And so a typical site for an intramuscular injection is the gluteal region. Anybody that's had a shot has had a shot in their butt, right? One thing we need to be really careful with is this giant nerve that everybody's seen in lab, this huge nerve back here called the sciatic nerve. And it passes through the gluteal region, and we need to avoid that whenever we do an intramuscular injection. So what's been established is the safest place to inject an intramuscular injection is going to be the upper outer quadrant of either gluteal region. So what does that mean? The gluteal region can be divided into quadrants, 2 imaginary lines that we draw this way and this way, and help us imaginarily kind of make a grid on the buttock. It's important to remember that the gluteal region extends as far forward as the anterior superior iliac spine, right? And the sciatic nerve curves through the upper lateral corner of the lower medial quadrant and descends along the medial margin of the lower quadrant. So it comes here and goes here. So this is where we want to inject in the upper outer quadrant. That way we avoid injuring the sciatic nerve. So as we move into the thigh, you're going to notice that it's a bit repetitious when it comes to the muscles that we've already seen that act on the hip. Some of these muscles cross the knee joint and actually act on the knee as well. So we'll get a little bit of a review as we move forward here. First of all, this slide just shows you what the thigh region is. It basically goes from the gluteal fold superficially down all the way through the femur, and anteriorly it's separated by the inguinal ligament. Posterior is separated from the gluteal region by the gluteal fold, right? So this fold in your buttock. So like we said before, structures enter and leave the top of the thigh by 3 routes. Posteriorly, the thigh is continuous with the gluteal region, and the major structure passing between the 2 regions is the sciatic nerve. Anteriorly, the thigh communicates with the abdominal cavity through the aperture between the inguinal ligament and the pelvic bone that we saw. and major structures pass through there, including iliopsoas, pectineus muscles, femoral nerve, artery, vein, and lymphatics. Medially, structures including the obturator nerve and its associated vessels pass between the thigh and the pelvic cavity through the obturator canal. The thigh itself, like we mentioned before, is subdivided into 3 compartments, and there's intermuscular septa or septae that divide these 3 compartments and keep them separated. Also, the fascia lata covers or completely surrounds the thigh muscles. Anteriorly, remember, if we can do a quick review, anteriorly in the anterior compartment has all the muscles that mainly extend the knee at the knee joint, all the quadriceps muscles. Also remember the rectus femoris is in there, which also helps flex the hip. It's a weak hip flexor. Posterior compartment, back in the back here, that's going to be comprised mainly of muscles that extend at the hip joint and flex at the knee joint, which are your hammies, right? And then medial compartment here is going to consist mainly of the adductors of the thigh at the hip joint, right? So, like we said before, quick recap, sciatic nerve tends to innervate the muscles in the posterior compartment of the thigh, femoral tends to innervate the muscles in the anterior compartment of the thigh, and the obturator nerve innervates most of the muscles in the medial compartment of the thigh. Okay, just a quick recap. There are some exceptions to this, but we're speaking in generalities here. The major artery, vein, lymphatic channels enter the thigh through the pelvic bone and pass through the femoral triangle inferior to the inguinal ligament, and the vessels and nerves pass between the thigh and the leg through the popliteal fossa posterior to the knee joint, which we will go over in this lecture. So another quick recap, we covered the proximal femur in the hip and gluteal region lecture, and now we're moving down towards the shaft and into the distal portion of the femur. We know that skeletal support for the thigh is from the femur, and it's a very large bone, which most of the large muscles in the thigh insert on. And then from there, for moving the knee joint, they're gonna they'll start there at the thigh, and then they'll insert into the bones of the leg, the tibia and the fibula. And they'll either flex or extend the knee joint. Remember, it's a hinge joint, so we only have flexion and extension. The distal end of the femur provides an origin for the gastrocnemius muscles, which we'll see when we get into the leg, which are predominantly in the posterior compartment of the leg, and they plantar flex the foot, right? The shaft and the distal end of the femur is bowed forward. You can see kind of this bowing, right? And has an oblique course from the neck of the femur to the distal end. So as a consequence, this oblique orientation in the knee is close to the midline under the body's center of gravity. So we saw that, how both of them kind of bow inward, right? Inward. And so that helps us have a steady center of gravity between the two knees. Let's see. We covered some of the important structures. We had the linea aspera. We had the two trochanters, right? As we get further down, we have a few things that are important to note. The distal end of the femur, the posterior surface forms the floor of the popliteal fossa, and its margins form the medial and lateral supracondylar lines, right? Here's the medial supracondylar line and the lateral supracondylar line. The medial supracondylar line terminates at the prominent tubercle, the adductor tubercle, on the superior aspect of the medial condyle of the distal end, right? There's the adductor tubercle. And just lateral to the lower end of the medial supracondylar line is an elongate, roughened area of the bone proximal to the attachment of the medial head of the gastrocnemius muscle. The distal end of the femur is characterized by two condyles, right? We have the medial condyle and the lateral condyle. We're looking at the thigh posteriorly here. Anteriorly here we have the lateral condyle, medial condyle. The condyles are separated posteriorly by an intercondylar fossa, and they're joined anteriorly where they articulate with the patella. The surfaces of the condyles that articulate with the tibia are rounded posteriorly and become flatter inferiorly. And on each condyle, there's a shallow oblique groove that separates the surface that articulates with the tibia from the more anterior surface that articulates with the patella. The surfaces that articulate with the patella form this V-shaped trench. Let me show you which faces anteriorly. Here's the V-shaped trench, right, on the patellar surface. And the lateral surface of the trench is larger, right, larger and deeper, steeper than the medial surface. And the walls of the intercondylar fossa bear two facets for the superior attachment of the cruciate ligaments, which stabilize the knee. And we'll get into the cruciate ligaments here pretty soon. So here you go. All right, so this is the patella. Remember, we talked about the largest sesamoid bone in the body, known as the kneecap or the knee bone, right? It's formed within the tendon of a muscle, which the quadriceps muscle, which is actually 4 heads of a muscle that come together, right? And then that crosses over the anterior portion of the knee and inserts on the tibia, right? So the patella is actually kind of triangular in shape, and its apex is pointed inferiorly for attachment of the patellar ligament, which connects the patella to the tibia. So we see all of the quadriceps muscles, the 4 of them, that come together to form this quadriceps tendon, which then inserts on the patella, and then the patella to the tibial tuberosity is the patellar ligament. So we have quadriceps tendon, patellar ligament. At the base, it's broad and thick, and attaches the quadriceps femoris muscle above, and then posterior surface. This posterior surface articulates with the femur, has a medial and lateral facet, which slope away from the raised smooth ridge, right? The lateral facet is larger than the medial facet for articulation with the larger corresponding surface on the lateral condyle of the femur, if we can remember from the picture before. Looking at the proximal end of the tibia, it's the tibia is medial and larger of the 2 bones in the leg. We have the tibia and the fibula, and it's the only one that articulates with the femur. So the fibula actually does not articulate with the femur, and the fibula doesn't actually help us in weight bearing. Only the tibia does. And so we have the medial condyle and the lateral condyle, which both flatten and then in a horizontal plane and overhang over the shaft, right? So here's the tibial surface, and here's the tibial tuberosity where the patellar ligament inserts. We have this cushiony layer here, the medial meniscus and the lateral meniscus. And those are our cushiony layer of our knee, which we will show in a little more detail moving forward. Just a few more things. This is the proximal tibia. So remember, we have the lateral condyle and the medial condyle here, and they're separated by the intercondylar ridge. And a lot of strong ligaments hold the knee together. We have the cruciate ligaments, and then we have the lateral medial ligaments. The articular surface of the medial and lateral condyles and the intercondylar region together form what's called the tibial plateau. The tibial plateau. And this articulates with and is anchored to the distal end of the femur, right? This is where the articulation takes place. Inferior to the condyles on the proximal part of the shaft is a large tibial tuberosity. Remember, we talked about the tibial tuberosity. And a little later, we'll talk about some pathology of the tibial tuberosity that can happen in kids. We We see the tibial tuberosity. We have muscle ligament attachments here. And then we have tibial condyles and intercondylar areas. We already talked about that. What else do we have here? Here's the articular facet for the proximal head of the fibula. So this is lateral, because we know that the fibula is lateral, right? We'll also talk in a little bit later about the attachment of the ACL and PCL, the posterior and anterior cruciate ligaments. And as it says here, this is the attachment for the patellar ligament. So now that we've looked at the tibia, we're going to look at the proximal end of the fibula. So as we said before, the fibula is the lateral bone of the leg, and it doesn't take any part in formation of the knee, nor does it take any part in weight bearing. So you can see, since it's not a weight bearing bone, it's actually really small and delicate, and it has a little small proximal head and a narrowed neck area, and then a very delicate thin shaft, which extends as the lateral malleolus as we get into the ankle area. Now, the head of the fibula is globe-shaped expansion of the proximal head of the fibula. And there's a circular facet right here on the superior medial surface for it to articulate with the tibia along the lateral condyle. And let's see, what else can we talk about? So, see the neck of the fibula, it separates the expanded head from the shaft. And remember that common fibular or common peroneal nerve lies against that aspect, that part of the neck. Let's see, what else? I think that's about it. All right, so we already talked about this. We're going to talk about it one more time. The muscles of the thigh arranged in 3 compartments. Anterior compartment contains sartorius and the quadriceps, all innervated by femoral nerve. And it also contains the terminal ends of the psoas major and the iliacus muscles, right? These muscles are innervated by branches directly off the anterior rami of L1 and L3, or form the femoral nerve, right? The iliacus is innervated by the femoral nerve as it passes down the abdominal wall. Medial compartment of the thigh contains 6 muscles. What are they? Gracilis, pectineus, adductor longus, adductor brevis, adductor magnus, and obturator externus. So mostly are the adductor muscles, right? And of all these muscles, all of them except for pectineus, which is innervated by the femoral nerve, and part of the adductor magnus, right? The hamstring part of adductor magnus is innervated by the sciatic nerve. Everything else is innervated by the obturator nerve, right? Because it's in the medial compartment. When we get to the posterior compartment of the thigh, we see right here, remember it has the 3 large hamstring muscles, all innervated by the sciatic nerve. Okay, so just a quick recap, this is important. And again, we've kind of already covered these. These are all the muscles in the thigh, and we just wanted to recap it, right? Here are the 2 major hip flexors, the psoas major and the iliacus. Pass on the terminal ends of these muscles, pass under the inguinal ligament and insert on the lesser trochanter. When we look at the quads, the quadriceps femoris, we have the 3 vastus muscles and we have the rectus femoris. What they do, only the rectus femoris crosses the hip, so that's the only one involved in flexion of the hip. All of them are major knee or leg extensors at the knee, right? They extend the knee. So if you think of when you have that patellar reflex, you hit that knee and the leg extends, that's those muscles kicking that leg out and extending that leg. These muscles also act in stabilizing the patella during movement, because that's where the quadriceps tendons attach, right? They are innervated by the femoral nerve, And the vastus muscles originate from the femur, but the rectus muscle from the pelvis, like we said. When we look at the patellar ligament, it's basically the continuation of the quadriceps tendon above the patella, and below the patella, it's the patellar ligament. And this is what attaches to the tibial tuberosity. And here are some more muscles. These are those in the medial compartment. And we can see them here. Again, remember they mainly adduct, and some of them help in medially rotating thigh. There's 6 muscles in the medial compartment. We say them again: gracilis, pectineus, adductor longus, adductor brevis, adductor magnus, and obturator externus. So again, all these muscles except for obturator externus mainly adduct the thigh at the hip joint, and the adductor muscles may also medially rotate the thigh a bit. Obturator externus, as we recall, is one of the 6 small lateral rotators of the thigh at the hip joint. The last one is gracilis, this thin little muscle, the most medial muscle and the most superficial in the medial compartment. And it comes vertically down the medial side of the thigh. And remember, as it comes down, it inserts onto the proximal shaft of the tibia, and it is sandwiched between the tendon of the sartorius in the front and the tendon of the semitendinosus in the back to form the pes anserinus, which we'll talk about a little later. A couple other muscles here that we want to talk about. We talked about it before, but we have the pectineus, which is right up here. It's a quadrangular muscle. What else? Adductor longus, we can see it here, and adductor brevis underneath. Adductor magnus with the adductor hiatus in here, and this is the hamstring portion of adductor magnus, which is innervated by the sciatic nerve, whereas all the rest of adductor magnus is innervated by the obturator nerve because it's in the medial compartment. Now we get in the posterior compartment. Here's a picture and here's a quick chart. We have the 3 hamstring muscles: biceps femoris, semitendinosus, and semimembranosus, and these muscles are responsible for extending the hip, extending the thigh at the hip, and flexing the knee at the knee joint. And these are all in the posterior compartment, so we're talking about the sciatic nerve, right? Great. All right, moving into the vessels. So remember, we have about 3 arteries that enter the thigh: the femoral artery, the obturator artery, and the inferior gluteal artery. And of these, the femoral artery is the largest and supplies most of the lower limb, right? Remember that femoral artery is nice and thick. The 3 arteries contribute to an anastomotic network of vessels around the hip joint. So they all kind of branch out around the hip joint, and we have some collateral circulation, right? When we talk about the femoral artery, because it's the biggest one, we want to talk about it first. It's the continuation of the external iliac. So we see the right common iliac here. We have the internal and external iliac, and as it travels down, it goes beneath the inguinal ligament, and then it becomes the femoral artery. And it's palpable in the femoral triangle. If you want to lay there and just try to palpate your pulse, you should be able to feel it there. It's about midway between the anterior superior iliac spine and the pubic symphysis. So the femoral artery passes vertically through the femoral triangle, and then it continues down the thigh in the adductor canal. You can see here in the adductor canal. It leaves the canal by passing through the adductor hiatus, so through that the little gap in the adductor magnus muscle called the adductor hiatus, and that's where it goes posteriorly to become the popliteal artery behind the knee. You also have a cluster of 4 small branches: the superficial epigastric artery, superficial circumflex iliac artery, the superficial external pudendal artery, and the deep external pudendal artery, which originate from the femoral artery in the femoral triangle and supply cutaneous regions of the upper thigh, lower abdomen, and the perineum. Then we want to talk about the deep artery of the thigh, right? the deep artery of the thigh is the largest branch off of the femoral artery, and it is also referred to as the profunda femoris artery because it's big and deep, profunda, right? Deep. Then it originates from the lateral side of the femoral artery in the femoral triangle, and it's the major source of blood supply to the thigh, right? The deep artery of the thigh immediately passes posterior between the pectineus and the adductor longus. So up here, you'll see that here's pectineus and there's adductor longus. You see, then it travels inferiorly between the adductor longus and the adductor magnus, eventually penetrating through the adductor magnus to connect with branches of the popliteal artery behind the knee. The deep artery of the thigh has lateral and medial circumflex femoral branches and 3 perforating branches. So that I think we'll see a little better on the next slide. Here we go. So we can see the deep artery of the thigh coming off of the femoral artery, and pretty quickly you see the lateral circumflex artery and the medial circumflex artery. Circumflex mean kind of, if you think of circumnavigation of the world, right? It's completely surrounding, right? It's circle. And then as we travel down, we have the penetrating arteries, right? Down a little further. You can see, or perforating artery, 1, 2, 3, right? It goes that way. Let's see what else. It can get a lot more technical than what we're getting right now. What we can say about the perforating arteries is they're branches off the deep artery of the thigh, and as it descends anteriorly into the adductor brevis muscle, and the first one of them originates above the muscle, the second originates anterior to the muscle, and the third originates below the muscle. And all 3 penetrate through the adductor magnus near its attachment to the linea aspera and enter and supply the posterior compartment of the thigh. Let's see, what else? I think that's probably good for the arteries. So we talked about the femoral artery and its branches. Now we're going to talk about the obturator artery. The obturator artery originates as a branch of the internal iliac artery in the pelvic cavity, and it enters the medial compartment of the thigh through the obturator canal, as we've previously discussed. It passes through the canal and it bifurcates into an anterior and a posterior branch, and they together form a channel that circles the margin of the obturator membrane and lies within the attachment of the obturator externus muscle. So vessels arising from the anterior and posterior branches supply all the adjacent muscles, and then they anastomose with the inferior gluteal and medial circumflex femoral arteries. And in addition, there's an acetabular vessel that originates from the posterior branch, and it enters the hip joint through the acetabular notch, and it contributes to the supply of the head of the femur. Remember, it travels with the ligament of the head of the femur and helps give supply to the head of the femur. Okay, so we covered the arteries. Now we're going to briefly cover the veins and the nerves. So veins are pretty easy. We have superficial veins and we have deep veins. So we talk about deep veins. Generally, they follow the arteries and they have similar names, which is good, right? We want easy. Same name as the artery and the vein when we're talking deep. Superficial veins are located generally in the superficial fascia, and they interconnect with the deep veins. They don't generally accompany arteries. So the largest of the superficial vein, as we recall, is the great saphenous vein, which we've already talked about. As far as nerves are concerned, there are 3 major nerves in the thigh. Each is associated with one of the 3 compartments. Remember, we already talked about it. Femoral nerve, anterior compartment, obturator nerve, medial compartment, sciatic nerve, posterior compartment. So let's talk about the femoral nerve quickly. Remember, It originates from the lumbar plexus, specifically spinal cord segments L2 through L4 on the posterior abdominal wall, and it enters the femoral triangle by passing under the inguinal ligament, right, the navel. In the femoral triangle, it lies most lateral. Remember, N in navel, so most lateral. Before entering the thigh, the femoral nerve supplies branches to the iliacus and the pectineus muscles. And then immediately after it passes under inguinal ligament, the femoral nerve divides into an anterior and posterior branches. And these supply the muscles of the anterior compartment of the thigh and the skin on the anterior and medial aspects of the thigh. And also the medial sides of the leg and the foot, right? So, branches of the femoral nerve. We have the anterior cutaneous branches. We have the motor nerves, which supply quadriceps femoris and the sartorius muscle. And then we have one long cutaneous nerve, the saphenous nerve, right? And it supplies the skin as far distal as the medial side of the foot. So it travels pretty far. The saphenous nerve accompanies the femoral artery through the adductor canal, but it doesn't pass through the adductor hiatus with the artery. Rather, the saphenous nerve penetrates directly through the connective tissue near the end of the canal to appear between sartorius and gracilis muscles on the medial side of the knee. Let's see what else we can talk about. Okay, so we talked about the femoral nerve and its branches. Now we're going to talk about the obturator nerve. The obturator nerve, branch of the lumbar plexus, spinal cord segments L2 through L4 in the posterior abdominal wall, just like the femoral nerve. It descends in the psoas muscle, and then it passes out of the medial margin of the psoas muscle to enter the pelvis. And remember, it follows the brim of the bowl of the pelvis and then goes through the obturator canal and supplies most of the adductor muscles and the skin on the medial aspect of the thigh. As the obturator nerve enters the thigh, it divides into two branches, right? It has the anterior branch and the posterior branch, which are separated by the adductor brevis muscle. And you can see that here. This is pictures of what I'm talking about. Here's the femoral nerve and its branches, the obturator nerve and its branches. Then we'll talk about the sciatic nerve. Remember, it's largest nerve. Excuse me. Sciatic nerve is a branch of the lumbosacral plexus, spinal cord segments L4 through S3, and it descends into the posterior compartment of the thigh through the gluteal region, right? It innervates all the muscles in the posterior compartment of the thigh, and then it branches to continue to the leg and the foot. So in the posterior compartment of the thigh, the sciatic nerve lies on the adductor magnus muscle, and it's crossed by the long head of the biceps femoris muscle. So proximal to the knee, and sometimes within the pelvis, the sciatic nerve divides into its two terminal branches, the tibial nerve and the common fibular nerve. So the sciatic nerve makes it easy, right? Because below the sciatic nerve, remember, it supplies most of the leg as well. The leg separates into the tibia and the fibula, so the sciatic nerve also separates into the tibial nerve and the common fibular nerve. Common fibular nerve, remember, we talked about wrapping around the neck of the fibula and being a risk for injury. So when we talk about the tibial nerve's right here, talk about the tibial nerve, it's part of the sciatic nerve, and it branches. Everybody's a little different. Sometimes it branches before and sometimes after the separation of the common fibular nerve. And it supplies branches to all the muscles in the posterior compartment of the thigh. And it innervates all of those except for the short head of the biceps femoris, which is innervated by the common fibular part. Let's see. The tibial nerve then travels, descends along through the popliteal fossa, and it enters the posterior compartment of the leg and continues all the way to the sole of the foot. So, tibial nerve is very important. It does all the muscles in the posterior compartment of the leg, all intrinsic muscles in the sole of the foot, including the first two dorsal interossei muscles, which may receive innervation from the deep fibular nerve. And it also does the skin on the posterior lateral side of the lower calf and leg, the lateral side of the ankle, the foot, the little toe, the skin, the sole of the foot, and the toe. So it does a lot. The tibial nerve is a pretty important nerve in the lower limb. When we talk about the common fibular nerve, it's a branch off the sciatic nerve. It innervates the short head of the biceps femoris in the posterior compartment of the thigh, and then it continues laterally. Remember, it wraps around the fibula, and it innervates all the muscles in the anterior and lateral compartment of the leg. One muscle, extensor digitorum brevis, in the dorsal aspect of the foot, the first two dorsal interosseous muscles in the sole of the foot, and the skin over the lateral aspect of the leg, ankle, and over the dorsal aspect of the foot and toes. So there you go. It's a lot of words. It's going to be a little hard to remember what innervates, but if you remember back to those charts, the myotome, dermatome charts, it'll be a little easier to remember which nerve innervates which muscles in which areas of the lower limb. All right, so moving on to the knee. The knee is one of my favorite joints. I like orthopedics a lot, and the knee is and injuries to the knee are actually pretty common, pretty popular. I wouldn't say popular, but a pretty common chief complaint, at least in the emergency department. It's the largest synovial joint in the body, and it consists of the articulation between the femur and the tibia, right? These are the two weight-bearing bones in the leg. The articulation between the patella and the femur, which allows the pull of the quads muscle and directed anteriorly over the knee to the tibia. And then we have, like we said before, we have these two fibrocartilaginous menisci or to form the meniscus, one on each side. You have medial and lateral, and it's located between the femoral condyles and the tibia, and it helps the smooth movement of the condyles on the tibial plateau. It also has pretty detailed movements of the knee and how it works together. I mean, as basic as you want to say it, it's a hinge joint. So mainly you get flexion and extension, but and well, like all hinge joints, the knee is reinforced by collateral ligaments, right? So you have the fibular collateral ligament and the tibia collateral ligament, right? Or the MCL and LCL, we call that a lot. The collateral ligaments holding the joint together, stabilizing it on the two sides. And then in the middle of the joint, or inside the joint, you have the cruciate ligaments, very strong ligaments that interconnect the adjacent ends of the femur and the tibia, and they help maintain their opposition points during movement, right? Because the knee is involved in weight bearing, it has a pretty efficient locking mechanism, right? Have you ever heard, my knee locked up on me, right? That's to help prevent and reduce the amount of energy required to keep the joint extended when you're standing. So if you stand up, you notice your knee locks into place, and that helps keep, I don't know, okay, the best way I can explain it is, have you ever tried squatting just a little bit, and you don't lock your knees in place? It puts a lot more stress on those muscles that keep the knee extended. And so by locking into place, the muscles that help you extend are no longer, firing, right? So they can kind of relax as your limb locks into place, which is important for us being on our feet and walking and being bipedal mammals, right? When we talk about the articular surfaces of the bones, the whole knee joint is covered by a hyaline cartilage, right? And we have the two articular surfaces on the distal end of the femur, which are the femoral condyles, and then the surfaces of the anterior aspect of the tibial condyles, right? So let's see. That's about it. So here's kind of a zoomed in picture of the menisci, right? So we have two. Like I said before, they're fibrocartilaginous. They're C-shaped in the knee joint. One's medial, and other lateral. and they're both attached to each in the facets of the intercondylar region of the tibial plateau. And let's see what basically what they do is they improve the congruency between the femoral and the tibial condyles during movements, right? And just basically the shock absorbers of the knee, right? And so as we tend to see degeneration over time of the knee joint, whether just because of elderly or because of wear and tear, you get breakdown of the meniscus, and that can cause a pretty significant knee pain, popping, locking, abnormal locking and popping of the knee joint. Here's an MRI capture of the meniscus, and it's just showing the normal cushion that a meniscus should have in the joint. Like we said before, the knee is the largest synovial joint in the body, and a synovial membrane of the knee attaches to the margins of the articular surface and the superior and inferior outer margins of the menisci, right? And very important in the way that the joint works smoothly. Let's see. Remember, there's also bursa. There's a prepatellar bursa and the infrapatellar bursa that help also with the patellar ligament and the quadriceps tendon and the patella as there to prevent friction from forming in there. So on top of that synovial membrane, then like we said before in the hip joint, we have to have the smoothness of the synovial joint, and then we got to throw in some stability. So we get this fibrous membrane that surrounds the knee joint, and it's reinforced by extensions of the tendons of the surrounding muscle. So this joint capsule just really helps reinforce the fibrous extensions of the iliotibial tract, all the muscles and the tendons and the ligaments themselves. And so it's really strong, helps with the integrity of the knee joint. And I think that's about it with that. Moving on to the ligaments of the knee. As we said before, there's several major ligaments associated with the knee joint. We have the patellar ligament, right? We already talked about that one. We have the tibial or medial collateral ligament and the fibular or lateral collateral ligament, LCL and MCL respectively, right? And then you have the anterior and posterior cruciate ligaments, or ACL and PCL. The patellar ligament, like we said before, it's basically the continuation of the quadriceps femoris tendon, inferior to the patella. The lateral or the collateral ligaments, one on each side of the joint, helps stabilize the hinge-like motion of the knee. And you have a cord-like fibular collateral ligament or lateral collateral ligament. It's attached superiorly at the lateral femoral epicondyle, just above the groove for the popliteal tendon. And then inferiorly, it attaches to a depression on the lateral surface of the fibular head. And it's separated from the fibrous membrane by a bursa. Then you have a broad, more flat medial collateral or tibial collateral ligament. It's attached to much of its deep surface in the underlying fibrous membrane, and it's anchored superiorly to the medial femoral epicondyle, just inferior to the adductor tubercle, and it descends anteriorly to attach to the medial margin and the medial surface of the tibia above and behind the attachment for sartorius, gracilis, and semitendinosus tendons, which form the pes anserinus right here. So when we talk about cruciate ligaments, I know if you've watched basketball, football, and pretty much any sport, you've heard athletes that tear their ACL. It's a pretty common injury. So what exactly is the ACL and the PCL? So we have, like we said, two cruciate ligaments. They are in the intercondylar region of the knee, and they interconnect the femur and the tibia. They kind of crisscross, right? So that's what cruciate means, right? Shaped like a cross. And because they cross each other at the sagittal plane between their femoral and tibial attachments, the ACL, anterior cruciate ligament, attaches to a facet on the anterior part of the intercondylar area of the tibia, right? And ascends posteriorly to attach to a facet at the back of the lateral wall of the intercondylar fossa of the femur. So if you think of ACL and PCL, the anterior and posterior refer to where they attach to the tibia, right? Not the femur, the tibia. So anterior attaches anterior part of the tibia. The posterior attaches to the posterior aspect of the tibia and ascends anteriorly to attach to the medial wall of the intercondylar fossa of the femur. Okay, so anterior cruciate crosses lateral to the posterior cruciate ligament as they pass through the intercondylar region, and the anterior cruciate ligament prevents anterior displacement of the tibia relative to the femur, and the posterior cruciate ligament restricts posterior displacement. So that's what this arrow signifies, is if I'm trying to pull the tibia forward, the anterior cruciate ligament is going to prevent the tibia from moving anteriorly. And if I try to push this posteriorly, the posterior cruciate ligament is what's going to prevent the tibia from sliding backwards, right? So you gotta pick. Let's always think about the ACL and PCL and how they relate to the tibia, because that'll help us from getting confused, okay? All right, so we talked about the locking mechanism. We said how important it was to help reduce the amount of muscle work that we need to maintain a standing position, right? Because if you just stand with just even a little bit of a flex at the knee, you work the muscles way harder than when you just lock your knees, right? So one component of the locking mechanism is a change in the shape and the size of the femoral surfaces that articulate with the tibia. And in flexion, so when the knees flex a little bit, the surfaces are curved and rounded. And as the knees extended, the surfaces move, and they move to the broad and flat areas. And this, consequently, the joint surfaces become larger and more stable when they're fully extended. Another thing that helps us lock the joint of the knee is this medial rotation of the femur on the tibia during extension. So you get a little bit of medial rotation and full extension, and it tightens the associated ligaments. One other feature that keeps the knee extended when standing is that the body's center of gravity is positioned along the vertical line that passes anterior to the knee joint. So the popliteal muscle unlocks the knee by initiating lateral rotation of the femur, and that unlocks the knee. So it's pretty cool how we're designed. We're energy efficient, upright beings, right? So everything and every little detail of how our bones, ligaments, muscles work helps us to be the most energy efficient beings that we can be, right? These three anatomical on purposeness features, right? Done on purpose to help us expend less energy when we're standing, right, for long periods of time. So when we look at the knee, we look at the vascular supply and the innervation. The vascular supply to the knee is predominantly through the descending and genicular branches from the femoral, popliteal, and lateral circumflex femoral arteries in the thigh, and the circumflex fibular artery and recurrent branches from the anterior tibial artery in the leg. And they form this anastomotic network around the joint, meaning they all kind of connect together. They form this little network here around the knee. And as far as the nerves are concerned, innervated by branches from the obturator, femoral, tibial, and common fibular nerves. So basically all the nerves help innervate the knee joint. Getting a little bit past the knee, right, we can see there's more ligaments that help keep the fibula and the tibia tightly connected, right? So we have this small tibiofibular ligament This is the joint right here. It's a synovial in type, and it allows very little movement. So these two bones, the tibia and the fibula, they stay pretty stuck close together. And then it's also reinforced by anterior and posterior ligaments. Anterior, posterior. So, let's see. All right, so like I said before, I told you we were going to talk about the popliteal fossa, and here we are. I want to talk about it a little bit. Popliteal fossa is this diamond-shaped fossa behind the knee. We talk about the margins. We want to talk about the upper margins first. It's a diamond. It has two upper margins, and they're formed medially. If we talk about medial, this is medially. They're formed by the distal ends of semitendinosus and semimembranosus, and lateral by biceps femoris. The margins of the lower part are going to be by the medial head of the gastrocnemius, and laterally by plantaris and the lateral head of gastrocnemius. And then the floor is formed by the capsule of the knee joint and adjacent surfaces of the femur, tibia, and more inferiorly by the popliteus muscle. The roof of the popliteal fossa is formed by deep fascia, which is continuous from what we know as the fascia lata from the thigh, and it travels downward, and that forms the roof. So what's important about the popliteal fossa? Why do we need to remember it? Well, it basically has to do with the contents of the popliteal fossa, which are the popliteal artery, the popliteal vein, and the tibial and common fibular nerves, right? So we already talked about the tibial and common fibular nerves. They originate proximal to the popliteal fossa as two major branches of which nerve? The sciatic nerve, right? And they are most superficial of the neurovascular structures in the popliteal fossa. They enter the fossa directly from above under the margin of the biceps femoris muscle. Then we have the popliteal artery, which is a continuation of the femoral artery in the anterior compartment of the thigh, and it begins as the femoral artery passes posteriorly through the adductor hiatus. Remember that little window in the adductor magnus muscle? So as the femoral artery passes through that, under that hiatus, it then becomes the popliteal artery. It appears in the fossa on the upper medial side, just under the margin of the semimembranosus muscle, and it descends obliquely through the fossa with the tibial nerve and enters posterior compartment of the leg. Let's see. Popliteal artery is the deepest neurovascular structure in the popliteal fossa, therefore difficult to palpate, right? So remember last semester when we were in patient encounter, we were trying to palpate the popliteal pulse, and you're like, wow, this is really hard. I can't really feel it. It's not the same as feeling a radial pulse or a carotid pulse where you feel it bounding, right? You feel a bounding pulse. When the way I describe feeling a popliteal pulse is you kind of feel just kind of like a little right? You feel it kind of give a bit. You have to really kind of zone in when you're palpating for it, and you can just kind of feel the whole area just swell a little bit with each pulse. And the reason for that is it's the deepest structure in the popliteal fossa, so it is difficult to palpate. When we are palpating, we want to palpate a little bit towards the midline, right? Midline of the popliteal fossa for that pulse. Let's see. In the popliteal fossa, the popliteal artery gives rises to branches which supply adjacent muscles, right? So a series of geniculate arteries which contribute to the vascular anastomosis around the knee. Remember, we just talked about that. So then the popliteal vein, remember, as we get deeper in the veins follow the arteries. So the vein is superficial to and travels with the popliteal artery. It exits the popliteal fossa to become the femoral vein by passing through the adductor hiatus. Remember, when we talk about veins, we talk about them from distal to proximal. So that's how that makes sense. Yeah, we already talked about the roof of the popliteal fossa, fascia, and then of course skin on top of that. The most important structure in the superficial fascia is the small saphenous vein. Remember that? This vessel ascends vertically from the superficial fascia on the back of the leg and from the lateral side of the dorsal venous arch of the foot, right? And then it ascends back to the back of the knee where it penetrates the deep fascia and it forms the roof of the popliteal fossa, and then eventually joins with the popliteal vein to come back up. So there you go. That's your popliteal fossa. We'll cover it again in class. Make sure we got that down, okay? So if we're wondering how the popliteal fossa is arranged and we can't remember it, Gonzales, I just can't remember which is on which side, right? There's a little mnemonic to help us remember. We can say the two semis go together, semimembranosus, semitendinosus. So membranosus is medial, right? Since the two semis go together, right? And then tendinosus is also medial, but it's on top of the membranosus. So by default, biceps femoris has to be lateral, okay? So why is it important that we know the compartments of the leg, the nerves, the arteries, all those things? Well, one important reason why we learn the different compartments of the leg and what passes through each one is because there's something called compartment syndrome. Compartment syndrome usually occurs when there's swelling from either infection, trauma, and the swelling occurs within the fascial enclosed muscle compartment. So the swelling swells within there, but it has nowhere to move because you have those septae between the muscles that keep them in the compartments. So when pressure in that compartment elevates, you get decreased capillary blood flow and then in turn decreased tissue perfusion, right? And so once the tissue is losing blood supply, it's losing oxygen, and it can lead to neuromuscular damage if we don't treat it. And so what they do is they get this pen or this device that checks the pressure of the compartment. And once they check the pressure of the compartment, they can tell if it's elevated. And in that case, the treatment for compartment syndrome is what we call a fasciotomy, where you actually externally cut the skin, the leg in that area to release the pressure on the compartment. And so this is something you want to be alert for in the clinics to make sure that that's not what your patient has. One other thing, when we were talking about the knee, remember we talked about how wonderful of a synovial joint it is. Well, over time, as with anything, you get wear and tear. And in medicine, that's called degeneration or degenerative joint disease, DJD. And that occurs throughout many of the joints in the body, the knee being one that's pretty strongly affected because it's such a large weight-bearing joint. You get degeneration from abnormal force across the joint with a normal cartilage or normal force with abnormal cartilage, right? So one of the most common sites for osteoarthritis are the small joints of the hands, right? Because we do a lot of fine motor skills with that. And then the knee is one of the more common ones. And what this picture is intending to show you is you get breakdown of the hyaline cartilage on the knee and the meniscal cartilage, and that breakdown causes grinding of the bone on bone. You've heard that before, I'm sure. You get erosion of that cartilage. And so it causes pain, discomfort, inflammation, stiffness. And so treatment in the first instance includes, changing of lifestyle and general anti-inflammatory medication. And then that leads all the way up to completely replacing the joint, where you have a complete total knee replacement, right? One other quick thing I want to talk about as far as the knee and the leg is the tibia, right? So we talked about this pes anserinus or duck's foot, and there's 3 muscles that come down and form this pes anserinus here in the tibia, and it's gracilis, and sartorius and semitendinosus. And so a way to remember this is a girl between two sergeants, right? So gracilis is sandwiched between sartorius anteriorly and semitendinosus posteriorly. And why this is significant is right beneath here in this area, there's a pes anserine bursa, and runners or people that start running kind of that haven't been active, or runners that are very active, as these hamstring and other adductor muscles insert on this bursa in here, it can become inflamed. We have weak hamstrings, so you got a lot of pulling on the bursa, and it can be very painful on the medial aspect of the tibia, kind of lower knee area. I've actually had it myself. I was 170 pounds, and I thought I was back in high school and college where I could run miles without having any issues. So I got out there and I started running, and my pes anserine bursa said, "No way, Jose." So I got a lot of pain and inflammation on my bilateral pes anserine bursas, and I had to strengthen up my quadriceps and my hamstring muscles to help when I would try to run. So I had to walk and kind of lead my way into full-blown running so that I was able to withstand, get these muscles strengthened up so they weren't pulling so hard on this bursa and inflaming it. So just something to look for pathological wise when you see your patients, and why anatomy is important. All right, so we're an hour in. We have about 10 more slides, 10 to 12 more slides to go. We're going into the leg. We're going to kind of hit it hard, so that way the last lecture we can kind of tidy up and do a little clinical correlation and then call it a day. So getting into the leg. We already talked about the gluteal region, the thigh, the knee, and now we're getting into the leg, right? So the leg is the part of the lower limb between the knee joint and the ankle joint. So proximally, we got most of the major structures that pass between the thigh and the leg through the popliteal fossa behind the knee. And distally, the structures pass between the leg and the foot mainly through the tarsal tunnel on the posterior medial side of the ankle. Exceptions being, there's always exceptions, right? Exceptions being the anterior tibial artery and the ends of the deep superficial fibular nerves, which enter the foot anterior to the ankle. So as we've mentioned previously, the bony framework of the leg consists of two bones, right? The tibia medially and the fibula laterally, and there are two parallel bones of the leg. Like we said before, the fibula is small on the lateral side, articulates superiorly with the inferior aspect of the lateral condyle of the proximal tibia. And remember, it does not take part in the knee joint, and it does not bear weight, right? The distal end of the fibula is firmly anchored to the tibia by a fibrous joint, and it forms the lateral malleolus of the ankle joint, right? The tibia, like we said before, is the weight-bearing bone of the leg, therefore much larger than the fibula, and above it takes part in the formation of the knee, and below it forms the medial malleolus and most of the bony surface for articulation of the leg with the foot at the ankle joint. The leg, similar to but different from the thigh, is divided into an anterior or extensor compartment, a posterior or flexor compartment, and a lateral or fibular compartment. There's also an interosseous membrane which links the adjacent borders of the tibia and the fibula across most of their length. There are two intramuscular septa which pass between the fibula and the deep fascia surrounding the limb, and direct attachment of the deep fascia to the periosteum of the anterior and medial borders of the tibia. So muscles in the anterior compartment of the leg dorsiflex the ankle. Remember, we have dorsiflexion and plantar flexion at the ankle, which is different. It's only specific to the ankle joint, right? So muscles in the anterior compartment of the leg dorsiflex the ankle, and if you'll put your fingers right on your shin area and you dorsiflex or bring your toe up, you can feel those muscles contracting and extending the toes. It also responsible for inverting the foot or turning the foot inward, right? Muscles in the posterior compartment, plantar flex, posterior plantar flex, PP, right? Posterior compartment, plantar flex the ankle. They also flex the toes, they grip them, right? And invert the foot, right? They help invert the foot with the muscles of the anterior compartment. Muscles in the lateral compartment evert the foot. So they pull the foot that direction, right? Eversion of the foot. Major nerves and vessels supply and pass through each of these compartments. And we'll kind of go into a little more depth on those a little later. Bones. So we already talked about them a little bit. Let's see what's important here. There's a few lines that are important. We got the soleal line that descends across the bone from the lateral side to the medial side where it merges with the medial border, which is right in here, soleal line. And that disappears in the lower 1/3 of the tibia. You got the shaft of the tibia that expands both the upper and the lower ends to support the body weight, right? So it expands, turns into a nice little skinny shaft here, but then expands up here so that it's weight bearing, right? The distal end of the tibia is shaped kind of rectangular box, right? It has a bony protuberance on the medial side, which is the medial malleolus here. The upper part of the box is continuous with the shaft of the tibia, while the lower surface and the medial malleolus articulate with one of the tarsal bones, which is the talus, to form a large part of the ankle joint. So the posterior surface of the box-like distal end of the tibia is marked by a vertical groove, right? And that vertical groove, which continues inferiorly and medially onto the posterior surface of the medial malleolus. This is the groove for the tendon of tibialis posterior muscle, and that's right here. You can see it back here. The lateral surface of the distal end of the tibia is accompanied by a deep triangular notch, or the fibular notch, to which the distal head of the fibula is anchored. So you can't see it here because the fibula is in place, but that's where the notch is, right there, where the fibula fits on there. So like we said, fibula is non-weight bearing. Fibular shaft is super skinny, narrow, and the ends of the fibula are enclosed by muscles, right? Excuse me, except for the end of the tibia. Except for the ends of the fibula, it's completely covered by muscles. Phew. And I think we'll cover that a little bit later. As we said before, as it comes down here, it forms the lateral malleolus, which is an area of kind of vulnerability or potential injury because of the ankle's flexibility, right? So I'm sure some of you have had a sprained ankle or seen a sprained ankle, and that's usually where we get the injury, along and around the lateral malleolar area. Joints. So like we said, there is a very strong, tough, fibrous sheet of connective tissue called the interosseous membrane that spans essentially the whole distance between the facing interosseous borders of the tibia and fibular shafts. So it basically travels almost the whole way. There are two apertures in the interosseous membrane, one at the top and the other at the bottom, and this is for vessels to pass between the anterior and posterior compartments of the leg. The interosseous membrane not only links the tibia and fibula together, but it also provides increased surface area for muscle attachment, similar to the obturator canal. Remember that, where had the obturator membrane, and that was a nice larger area for muscles to attach. So it's similar here. We have more surface area for muscles to attach. The distal ends of the fibula and tibia are held together by the inferior aspect of the interosseous membrane. And then we have corresponding ligaments at the end, right? So Here towards the bottom, we have the posterior tibiofibular ligament, and then we have the anterior tibiofibular ligament. And those link them together. So this is looking at the posterior compartment of the leg. We're looking at the muscles. Remember, these muscles are posterior, so they plantar flex and invert the foot, flex the toes, and they're all innervated by the tibial nerve. You have this, which is called the superficial group. Superficial group of the muscles in the posterior compartment of the leg are three muscles, right? Gastrocnemius, plantaris, and soleus. And they all insert onto the heel, the calcaneus of the foot, and they plantar flex the foot at the ankle joint. So as a unit, these muscles are large, powerful, because they propel the body forward on the planted foot during walking, and they can elevate the body upward on the toes, right? We stand on our tippy toes. So if you'll get up and stand on your tippy toes, you can feel that the calf muscles, right, pushing you upward. So two of the muscles, gastrocnemius and plantaris, originate on the distal end of the femur, and they can also help flex the knee, right? If we think about the muscles, gastrocnemius is the most superficial in the posterior compartment. It's one of the largest muscles in the leg, right? It originates from two heads, one lateral and one medial, and the medial head is attached to a roughening on the posterior aspect of the distal femur, just behind the adductor tubercle. And then the lateral head originates from the distinct facet on the upper lateral surface of the lateral femoral condyle. And then, let's see. So in the upper leg, the heads of gastrocnemius combine to form a single elongate muscle belly, which forms much of this soft tissue bulge that we like to call a calf, right? In the lower leg, the muscle fibers of the gastrocnemius converge with the soleus, and they form the calcaneal tendon, or what we like to refer to as the Achilles tendon, right? And those attach onto the heel of the foot. Like we said, the gastrocnemius plantar flexes the foot at the ankle, and can also flex the knee at the knee joint, right? Innervated by tibial nerve. Plantaris. So this is a small muscle. It has a small muscle belly proximal to a long, thin tendon. And this tendon descends through the leg joints and joins the calcaneal tendon, right? The muscle takes origin superiorly from the lower part of the lateral supracondylar ridge of the femur and from the oblique popliteal ligament associated with the knee joint. And then the short spindle-shaped muscle of the plantaris descends medially and deep to the lateral head of the gastrocnemius and forms a thin tendon, which then passes between gastrocnemius and soleus and eventually fuses with the medial side of the calcaneal tendon. So again, it does plantar flexion, the foot and the ankle joint, and flexion of the knee at the knee joint, and it's innervated by the tibial nerve, because they all are, right? Last superficial muscle is, we have the soleus, right? Soleus is a large flat muscle. I think of it like the sole of the foot. If you're flat-footed, you got a soleus foot, right? So it's a large flat muscle under the gastrocnemius, and it's attached proximal to the ends of the fibula and tibia, and it has a tendinous ligament which spans the distance between the two heads of the attachment of the fibula and tibia. And then the soleus muscle narrows to join the calcaneal tendon and then attaches to the calcaneus. So we have soleus plus gastrocnemius and plantaris, and all those three muscles help you stand on your tippy toes, plantar flex the foot and the ankle, and they're all innervated by tibial nerve. So here you go. All right, now we're getting into the deep group, right? These are a little bit more complicated. There are 4 muscles in the deep posterior compartment of the leg. We have the popliteus muscle, the flexor hallucis longus, the flexor digitorum longus, and the tibialis posterior. The popliteus muscle acts on the knee, whereas the other 3 muscles mainly act on the foot. So the popliteus, again, is the smallest. It's this little tiny little muscle up here. It's the smallest, most superior of the deep muscles, and it unlocks the extended knee. Remember we talked about how our knee locks? Well, this muscle is the one that initiates the unlocking, right? By resisting lateral external rotation of the tibia on the femur. Let's see what else. It is innervated by the tibial nerve, right? Then we have the flexor hallucis longus. And this muscle originates on the lateral side of the posterior compartment of the leg and inserts under the plantar surface of the great toe on the medial side of the foot, right? So we see flexor hallucis longus. So we know it flexes, and the hallux is the big toe, right? And longus because it travels a long distance to get there, right? And so basically what it does is it flexes the great toe. It does what it says it's going to do. And this is particularly active during the toe off phase, right? When you're walking, you push off, propelled forward, and that's what helps us do that. It also contributes to plantar flexion of the foot and the ankle and is innervated by, again, the tibial nerve. Then we have the flexor digitorum longus. So kind of like the name says again, it flexes the digits, right? And it's long because it starts up high. So it basically flexes the lateral 4 toes, and it's involved with gripping, right? Gripping, we need grip to walk and to propel off of the floor. And it's, again, innervated by the tibial nerve. Last of the deep posterior compartment is the tibialis posterior. And this muscle originates from the interosseous membrane and adjacent posterior surfaces of the tibia and fibula. And near the ankle, the tendon of the tibialis posterior is crossed superficially by the tendon of the flexor digitorum longus muscle, and it lies medial to this tendon in the groove on the posterior surface of the medial malleolus. You see how it travels here. And the tendon curves forward underneath the medial malleolus and enters the medial side of the foot, right? It has to be, enters the medial side of the foot, and it wraps around the medial margin of the foot to attach to the plantar surface of the medial tarsal bones. And mainly it attaches to the tuberosity of the navicular and to the adjacent region of the medial cuneiform. And so what this does is it inverts, it brings the foot in, and it plantar flexes the foot. And it also supports the arch of the foot, the medial arch of the foot during walking. And again, innervated by the tibial nerve. Okay, so quick. We're already not so quick, but let's go quicker. Hold on. So I think it's important to stress that when we're doing the integrities, I'm trying to give you a lot of detail, more detail than what I can give you in class. So if you're like, geez, Gonzales, this is a lot of stuff. Yeah, it is. And it's more than what I can do in class. So this is where we got to hit it hard, get all the details in, and then in class, we'll kind of review the important stuff, the big stuff, and it'll all come together, right? So we talk about the arteries. We have the popliteal artery. Remember, it's the major blood supply to the leg and the foot, and it enters the posterior compartment of the leg from the popliteal fossa. And this is behind the knee, like we saw earlier. The popliteal artery passes into the posterior compartment of the leg between gastrocnemius and popliteus. And as it continues, it passes under the tendinous arch formed by the fibular and tibial heads of the soleus muscle. And it enters the deep region of the posterior compartment of the leg, where it immediately divides into anterior tibial artery and posterior tibial artery. We also have 2 large sural arteries, one on each side, and they branch from the popliteal artery to supply the gastrocnemius, soleus, and plantaris muscles. And in addition, you have the popliteal artery. It gives rises to the branches that contribute to a collateral network of vessels around the knee joint that we saw earlier. The anterior tibial artery, this passes forward through the aperture in the upper part of the interosseous membrane and enters and supplies the anterior compartment of the leg. Okay, it makes sense, right? It continues inferiorly and onto the dorsal aspect of the foot. The posterior tibial artery, remember the posterior tibial pulse? We felt that in patient encounter. This supplies the posterior and lateral compartments of the leg and continues onto the sole of the foot. The posterior tibial artery descends through the deep region of the posterior compartment of the leg onto the superficial surfaces of tibialis posterior and flexor digitorum longus. And in the leg, the posterior tibial artery supplies adjacent muscles and bone and has two major branches. We have the circumflex fibular artery and the fibular artery. The circumflex fibular artery passes laterally through the soleus muscle and around the neck of the fibula, and that connects with those knee anastomotic network. And then you have the fibular artery, which parallels the course of the tibial artery, and it descends along the lateral side of the posterior compartment adjacent to the medial crest on the posterior surface of the fibula. And that then separates into the attachments of the tibialis posterior and the flexor hallucis longus muscles. The fibular artery supplies the adjacent muscles and bone to the posterior compartment of the leg and also has branches that pass laterally through the intermuscular septum to supply fibularis muscles in the lateral compartment of the leg. We have a perforating branch that originates from the fibular artery distally to the leg and passes anteriorly through the inferior aperture in the interosseous membrane to anastomose with a branch of the anterior tibial artery. Whew, that's a lot. Veins. Okay, so deep veins, when we think of deep veins, what do you think of? DVT, right? Deep vein thrombosis. That's why these are important. Deep veins basically lie in the posterior compartment and they generally flow with the arteries. That's about all I got for veins. As far as nerves are concerned, we've seen one that's popped up a whole bunch, the tibial nerve, right? So the nerve associated with the posterior compartment of the leg is the tibial nerve. It's a major branch from the sciatic nerve, we remember, from a little higher up, and it descends into the posterior compartment from the popliteal fossa. So the tibial nerve passes under the tendinous arch formed by the fibular and tibial heads of soleus muscle, and then it passes vertically through the deep region of the posterior compartment of the leg on the surface of tibialis posterior. Same with the posterior tibial vessels. The tibial nerve leaves the posterior compartment of the leg at the ankle, passing through a tarsal tunnel behind the medial malleolus, and it enters the foot to supply most of the intrinsic muscles and skin. And in the leg, the tibial nerve gives rise to branches that supply all the muscles in the posterior compartment of the leg. Two cutaneous branches, the sural nerve and the medial calcaneal nerve. And then branches of the tibial nerve that innervate the superficial group of muscles in the posterior compartment and popliteus muscle of the deep group originate high in the leg between the two heads of the gastric muscles and in the distal region of the popliteal fossa. And these branches innervate gastrocnemius, plantaris, and soleus. Let's see, what else? We talked a little about the sural nerves. They originate high in the leg between the two heads of gastroc, and then they descend superficial to the belly of the gastrocnemius muscle and penetrate through the deep fascia in the middle leg, where it's joined with the sural communicating branch from the common fibular nerve, and it supplies the skin, the lower posterior lateral surface of the leg, and the lateral side of the foot and the little toe. And then we have one more, the medial calcaneal nerve, and this nerve is often multiple, and it originates from the tibial nerve low in the leg near the ankle, and innervates the skin to the medial surface of the sole of the heel, right? Calcaneus heel. All right, so we're in the lateral compartment of the leg. So lateral compartment, on the lateral side, two muscles. So we got this, right? Two muscles. They are fibularis longus and fibularis brevis. Both evert the foot. So it seems a little counterintuitive, right? Because it's on the lateral side. You think it would invert, but if you think about it, it pulls the foot outward, right? Because they contract and they pull the foot outward and they evert it, right? They turn the sole of the foot outward. And they're both innervated by the superficial fibular nerve, which is a branch of the common fibular nerve. So breaking down those two muscles, we have fibularis longus. This muscle arises in the lateral compartment of the leg, but its tendon crosses under the foot to attach to bones on the medial side. And it originates from both the upper lateral surface of the fibula and from the anterior aspect of the fibular head, and occasionally up to the adjacent region of the lateral tibial condyle. So the common fibular nerve passes anteriorly around the fibular neck, between the attachments of fibularis longus to the fibular head and shaft. And then the fibularis longus descends in the leg to form a tendon, which in order it passes posterior to the lateral malleolus, right, in this little bony groove, and then it swings forward to enter the lateral side of the foot. Then it descends obliquely down the lateral side of the foot where it curves forward under a bony tubercle, and then it enters a deep groove on the inferior surface of one of the other tarsal bones, the cuboid, and then swings under the foot to cross the sole and attach to the inferior surfaces of the bones of the medial side of the foot, the lateral sides of the base of the metatarsal, and the distal end of the medial cuneiform. So what does it do? It everts the foot and it plantar flexes the foot a little bit. And it also, in addition to tibialis anterior and tibialis posterior, they all insert in the undersurface of the bones of the medial side of the foot, and they act as a stirrup support for the arches of the foot. So that's really important. It mainly supports the lateral and the transverse arches. It's innervated by the superficial fibular nerve. The other muscle in the lateral compartment is fibularis brevis. This muscle is deep to fibularis longus in the leg and originates from the lower 2/3 of the lateral surface of the shaft of the fibula. And this assists in eversion of the foot. It's innervated by the same superficial fibular nerve. We already talked a bit about the common fibular nerve and some of its branches. As far as arteries are concerned in the lateral compartment, there are no major arteries that pass vertically through the lateral compartment of the leg. It's mainly supplied by branches, mainly from the fibular artery and the posterior compartment of the leg, and they kind of penetrate through to help supply that area. These are the superficial fibular nerve. Is the one that we see the most in this area. Anterior, last compartment, anterior compartment of the leg. There are four muscles. There's tibialis anterior, extensor hallucis longus, extensor digitorum longus, and fibularis tertius. Collectively, they dorsiflex the foot at the ankle, and they extend the toes and invert the foot. And they're all innervated by the deep fibular nerve, which is a branch of the common fibular nerve. So, just to go through each muscle, tibialis anterior is the most anterior and medial of the muscles in the anterior compartment of the leg. The muscle fibers of the tibialis anterior converge in the lower 1/3 of the leg to form a tendon, which descends to the medial side of the foot where it attaches to the medial and inferior surface of the tarsal bones, namely the medial cuneiform and part of the metatarsal. Tibialis anterior dorsiflexes the foot, right, and inverts the foot. During walking, it provides dynamic support for the medial arch of the foot. And it's innervated again by the deep fibular nerve. All these muscles are. Then we have extensor hallucis longus. Remember, in the posterior compartment, we had flexor hallucis longus. Now we're talking about extensor hallucis longus, which extends right? Extends the great toe. And it also dorsiflexes the foot at the ankle joint. Like all of them in the anterior compartment, it's innervated by the deep fibular nerve. Then we have same thing like in the posterior compartment, we had the flexor digitorum longus. Now we have the extensor digitorum longus, which is the most posterior and lateral of the muscles in the anterior compartment, and it extends the digits. So it basically comes down, descends to form a tendon which continues into the dorsal aspect of the foot, and it divides into 4 tendons which they insert on the dorsal surfaces of the bases of the middle and distal phalanges, and they extend the toes and dorsiflex the foot at the ankle, and it's innervated by the deep fibular nerve. Last muscle in the anterior compartment is the fibularis tertius. Muscle is normally considered part of the extensor digitorum longus, but it originates from the medial surface of the fibula and basically assists in dorsiflexion and possibly even a little bit of eversion of the foot, and it's innervated by the deep fibular nerve. As far as arteries go, we have the anterior tibial artery. This is associated with the anterior portion, anterior compartment. Let's see. As far as veins go, deep veins follow the arteries, have similar names. And as far as the nerves go, we have the deep fibular nerve. This nerve is associated with the anterior compartment of the leg, and it originates in the lateral compartment of the leg as one of the 2 divisions of the common fibular nerve. And the deep fibular nerve passes anteromedially through the intermuscular septum that separates the lateral and the anterior compartments of the leg, and then passes deep to the extensor digitorum longus. And the deep fibular nerve, remember we said, innervates all the muscles in the anterior compartment, and then continues to the dorsal aspect of the foot where it innervates the extensor digitorum brevis and contributes to the innervation of the first 2 dorsal interosseo muscles, and supplies the skin between the great and second toes. So clinically, I have here the Achilles tendon rupture. So remember that in the posterior compartment, we have the tendons that come together from gastrocnemius and soleus, and they come together to form the calcaneal tendon, or the Achilles tendon, as it's often referred to, and it's related to sudden direct trauma. And this type of injury frequently occurs in a normal, healthy tendon, unfortunately. And there are other conditions and medications that you can have that can make you predisposed to having tendon injury. So basically, patients feel like they get kicked or shot in the back of the ankle, and often when you do an exam, you can feel a gap where the tendon has ruptured. The way that you diagnose this is you have the patient lay prone on the bed with the foot dangling off the edge of the bed, and you go and you squeeze the gastroc or the calf area. You squeeze those muscles, and in a normal Achilles tendon, you should see plantar flexion of the foot. But in this case, because the tendon is disassociated with the calcaneus, you don't have the normal plantar flexion when you squeeze the calf, and you don't get any movement. And this is called a positive Thompson test. I remember I was having a little trouble remembering my lumbar plexus. I know we're a little late for this. This is a little bit last lecture and maybe the pelvis, but I have a mnemonic. I didn't teach it to you. I just found it on the internet, but it helps us remember the different branches of the lumbar plexus, and I'll let you read that on your own. That's all I got for you. It's a long lecture, almost 2 hours. I know that's a lot of material to cover, but if I don't cover it Now, I certainly am not going to have this much time in class, and I really want to hit the high points in class. So I appreciate you guys putting the time in to learn this material. It's a lot of stuff, a lot of memorization. But if you take it compartment by compartment here in the leg and the thigh, I think it's doable. I think it's fairly simple. It's just a lot to remember, but it's not complicated. So take the time, repeat. Repetition is the way you're going to get it. Watch those YouTube videos. I don't know if you want to watch my integrity more than once. I probably wouldn't, but watch it if you need to. The more you see it, the more you hear it, the more you're going to remember it. And we'll cover this in class on Monday. Thank you.